Well, we are at top of the hour here. And so let me go ahead and share my screen. Just to get us started. And Jessica and Karen, oh, there's Ryan. Excellent. I just saw him came in. We're in great shape, so this is perfect. Welcome everyone to my November edition of Marilee's Office Hours. Today we have a very special guest speaker straight from DC, like literally in the middle of important conversations, Ryan Howells. And I'm going to talk more about Ryan in a minute and do an introduction. But first, a few housekeeping items. As those of you get logged in, you just heard me make a case for please turning on your camera. Jean is giving you an example of how that works. So we love to see your smiling faces. I know there's a few of you that aren't in position to do that, but when you can, we love to see you personally. So let's get started here because I do want to allow Ryan lots of time, but just a little bit of homework or housekeeping, if you will. First of all, I'm declaring November officially Interop Month because there's a lot going on this month for those of you who may be not aware. First of all, I guess today and tomorrow there are meetings in DC with the administration. I know tomorrow specifically is the CMS Interoperability Frameworks meeting. Was a meeting I unfortunately wasn't able to get to, partly because there are more meetings next week. So next week in Nashville, we have the eHealth Exchange annual meeting on Tuesday. Then right after that, we have the Care Quality annual meeting on Wednesday. And then last but definitely not least, we have the Sequoia Project, who of course is the TEFCA RCE on Thursday. This is kind of my favorite time of the year. These meetings are just extraordinarily valuable for those of you participating in national network initiatives, whether that be through eHealth Exchange, Care Quality, Commonwealth, or TEFCA. So, and those of you who aren't speaking, it'd be great to, and maybe Jessica, if you could, and Karen, you could help maybe mute some audios there. Thanks. So we're very excited about all the great conversations that are going on. That's really, couldn't be more exciting. And in December, speaking of those meetings, I am going to do my office hours a little earlier in December to avoid the holidays. So please hold the date for December 10th at noon Central. We're actually having another guest speaker. They're going to be from Plant Moran. They are security, a big consulting company. They also do a lot of high trust and SOC 2 and other kinds of security audits. We're going to kind of talk about the latest security concerns and news related to healthcare. And I'll also include in that meeting a national network meeting recap for all those meetings that are going on here this month. With that, I am going to go ahead and do a quick introduction to Ryan, and who has so graciously joined us from DC, kind of literally stepped out of meetings ongoing to join us here and give us his perspective on all things happening with digital health policy and interoperability. Ryan is a partner with Leavitt Partners. He collaborates with the private sector, the administration, HHS, and the VHA to improve healthcare nationwide. If you've heard the term "kill the clipboard," you can thank Ryan and his team because they wrote a white paper in March, and the CMS, I think, rightfully picked that up, and it's part of the big initiative here. Ryan also co-leads the Karen Alliance, which obviously is playing a very important role in driving advancements for consumer directed exchange, and then works with CMS and CQA on digital quality measures. And I think one thing that he's working on that's super exciting to me in particular is the work that they're doing there in Utah, the first statewide multi-payer, multi-provider FHIR API interoperability initiative. So that's super exciting work. So these are some of the things that Ryan's going to talk about today. And Ryan, before I change while I'm changing my screen share here, I will let you do a quick hello to everybody.
Hello, everyone from DC. Good to see you. I'm excited to be here today, and I'm going to take myself off video so that you can see my mugshot there on the screen, I guess, which is interesting. But Marilee, thank you for the opportunity. We appreciate it. It's always great to be able to talk to other fellow compatriots in this fight we have to try to increase interoperability. So grateful for all that you do and all that everyone else is doing to actually make this really be able to scale. So yeah, as Marilee mentioned, I'm going to talk today, hopefully for a fairly short amount of time, maybe 20 minutes or so, and then we'll just open it up for questions. And if you've got any questions, throw them in the chat if you could. I'm typically good at a little bit multitasking. Marilee can keep us honest as we're going through this. But yeah, so let's kind of dive in. There's been a lot going on in the last 10 months. And as Marilee mentioned, we did write a paper back in March, presented it at HIMSS around Kill the Clipboard and what that potentially could mean. And there was about 16 pages. You can Google it and kind of see it. But I want to be clear, and I've been clear in other entities too. These were not our ideas. These, meaning Leavitt partners, they were all of our ideas. Like everybody, on this phone call, as we go around the country, we're agnostic to who provides us the idea. we hear good ideas and we like that's a great idea, and if we can get enough consensus around it, we want to put it in there. So we did that, and we put a lot of these things in there in the paper, and a lot of them, as Marilee mentioned, the administration took up as being kind of real priorities. I would guess that I think the biggest thing, there's a lot of TEFCA ideas in terms of how to improve TEFCA. I know folks are a little frustrated that more payers potentially aren't participating in TEFCA. I think there's a lot of reasons for that. So we did engage with a lot of payers as to why that's the case. I think one of the big ideas here is the first one. We think that there are opportunities for us to increase innovation both inside the EHR and outside the EHR if we could actually change the definition of CERT and change the definition of kind of a base EHR. What we mean by that is there an opportunity for us to, instead of certifying functionality, which is really what ONC does today, is there an opportunity to actually certify interfaces, certify the APIs and other interfaces? We were pleased to see that, generally speaking, that the EHRA is supportive of this kind of idea, where we can move away from that and this kind of certifying functionality inside the EHR. What that will mean is that instead of EHRs kind of waiting on the feds for a product roadmap and their clients, they can just focus more on their clients. So more innovation can happen inside the EHR and outside the EHR. By receiving that data in a standardized format, then we can have cloud-based innovative technologies that allow for this to be able to do non-EHR specific workflows. And so that's kind of an exciting one. We'll see what happens on that one, but that was kind of probably the most, maybe the spiciest one that was in there, but there was a number of spicy ones. So we'll go to the next slide. In July, as folks know here, that there was an announcement from the administration around the Health Tech Initiative and the Kill the Clipboard Initiative. There were 60 organizations that participated in that initial launch. But I think the key thing that the administration has said is that really that was just a representative sample. It was just, hey, we reached out to 60 companies and they all said yes, and anyone can actually join. And they have also been public with the fact that there's, I think, 400 other organizations that have simply just filled out a form and said, we also want to participate in this and we're supportive of that. And so the barrier to entry here is just filling out a form. So if you go to that website, and if you're an organization that wants to commit to one of those voluntary commitments that have been made there, you can do that, and you can participate in this effort. In fact, a lot of the people that will be there tomorrow will be people that have recently filled out that form in the last 2 or 3 months and have an opportunity to be able to get connected to some of these ideas. So next slide. Folks, I think, know about the Karen Alliance, but just for those who don't, we've been around since 2016. We're an HL7 FHIR accelerator. We've got about 70 organizations that are participating in here, including a lot of different patient advocates and others. The goal has been to find ways where individuals can get access to their own health information, where, when, and how they want to achieve their goals. We didn't put this in here, but it's using a FHIR API and an app of their choice from any payer and provider in the country. The interesting positive consequence from starting Karen was the fact that we are now the most mature community in the country that have implemented FHIR in production. And so these third-party applications that have been doing patient access now for a while have more experience in FHIR in production than anybody else, any of the payers or providers that are out there. So our goal now is to not only continue to improve and increase patient access, but also to help others understand what we've learned with FHIR in production and share that as we move to a B2B environment, business to business environment. So people, FHIR environment for the CMS 0057 rule in January next year, and just be able to say, hey, look, here's what we learned. This could be helpful for you. We think that this is how apps will be able to connect in the future. And so there's opportunities there. And so on the next slide, it gives you an idea of some of the things that we've done in Karen. We help write with many of our friends from the Blue Cross Blue Shield Association and others, the Karen IG for Blue Button, which is now the claims and administrative data model for the whole country for FHIR-based APIs. US CDI, US Core is run by Argonaut and obviously ONC. But this is now the claims data model for the whole country, and it's being used at scale. So if we want health plans to have data that's shareable, feel free to let us know what those data elements are, because that's really now going to become the default data model for the country. Digital insurance cards is really exciting. That was in the Kill the Clipboard CMS initiative. We have this, I kind of joke Marilee a little bit, but like, it's not really a joke, that we have this thing called revenue cycle management that probably shouldn't exist because systems don't talk to each other. And 30% of the time, a person comes into a health system and they don't have an insurance card. And therefore, one health system told me they have 1,000 people that they've hired to actually track down money that they're owed. It's just crazy. Like those are the things we've got to stop. And we want to redeploy those folks into care because we have such a shortage of clinicians and other support individuals to help with that. So digital insurance card is going to help with that. Just so you know, there's actually more than 1.5 million now in production. We have about 5 or 6 of the major nationals that have actually gone live with digital insurance card. Epic's gone live with it too. And we have actually more than 1 million a month on just those kind of handful of folks that are being exchanged today, which means in the future, you're going to see a world where you'll choose your PCP during open enrollment. And after you've chosen your primary care physician, when you show up to the doctor's office, a lot of the time, especially for your primary care physician, you won't even need to show your insurance card anymore. They'll already have it. And that's the benefit of interoperability. But if you go to a specialist and they may not have it, you can bring it along with you. And we're actually talking about that tomorrow, how that workflow would actually operate. Digital identity is a big one. We've been promoting it since 2017. We got to know who we say you are across systems. And then real-time benefit check, 50 to 75% cost savings on that. 7 states require it, which is really great. And we're going to see some good stuff about that. So on the next slide, I think folks know about kind of our digital identity work that we've been doing. I think the key points here are, 1/3 of Americans have one. So it's not something that is, foreign. It's absolutely something that's out there. We do need to put our trust somewhere. And the good news about putting our trust in the identity layer is that there are sectors of the American economy outside of healthcare that's helping to oversee these identity vendors. So whether it's financial services or Social Security Administration or VHA or federal government, you name it, like everyone's IRS, everybody is focused on making sure that this is right and that there's a high degree of fraud prevention here as well. So that gets me excited because unfortunately with healthcare, historically, we haven't done a great job of kind of overseeing ourselves in terms of how we do transactions and other healthcare type things. And so I want to put our trust where not only healthcare is kind of overseeing this and making sure it's right, but also literally all other industries. I mean, it's foundation. It's going to be foundational to the internet, and some of the smartest people in the country are working on digital identity across the board. And so that's pretty exciting. On the next slide, there's some information about digital insurance cards. As I mentioned, that's there's over 1 million a month are being exchanged today. We've had a great uptick. The Kill the Clipboard initiative from CMS is going to help enable that and really try to move that forward in a meaningful way. There's a lot of providers that are excited about this, as you can imagine, because they'll be able to redeploy folks in other areas other than just trying to chase down someone's insurance card. And you know, busy moms that come into a PCP, you know, the last thing they want to do is kind of take that out of their, you know, fill out that clipboard. So how can we figure out ways to make that happen? So we've got a connect-a-thon and all kinds of fun stuff in the HL7 community. If you want to join that, we're looking for more providers to adopt this over time. We've got a lot of payers that have now signed on. We're looking for some more providers too. On the next slide I say a lot of spicy things, I guess, Marilee, but this is maybe another spicy topic, which I've been saying over the fall, that I just don't see a way in which payment and operations is going to work on national TEFCA by 2027. I don't see that actually happening. And there's a whole bunch of reasons for that. I guess the biggest reasons are that fact that we're quite kind of not there yet with kind of the FHIR architecture for what's needed. I know they're working on it. I think the biggest problem actually isn't technical, it's actually more policy driven. One of the assumptions that we made going into this was that folks would essentially abandon their data use agreements with each other, payers and providers, and they would adopt a common agreement flow downs and everything would be hunky dory. But we don't kind of live in that world. We live in a world that's unfortunately a lot more contentious than that. And when payers and providers get together, it's usually very, very contentious. And so what we're trying to figure out is to say, look, there's a lot of negotiation that has taken place from a data use agreement perspective. And there's reasons for that. You know, there's certain data that payers need. They don't need necessarily all of it. There's certain data that providers need. They may not need all of it, but they're specific to the individual use cases that they need. And so one of the things we've done is the Utah initiative, as Marilee mentioned at the beginning. Utah initiative is exciting because the governor called us up and invited us in to do this. And we have learned a lot about all of these different initiatives. Mainly it's around 0057, but we've added a few more in here. A few things we've learned is, number one, in order for us to be successful with this, we're going to have to get on a similar product roadmap. I know that's going to be really, really hard, but providers and payers are going to have to be able to be more upfront and transparent with each other, to be able to say, look, here's when we're ready to test. Here's where we're going to be ready to actually exchange data back and forth. And here's when we can test with you. And then there's also ways to implement the 0057 rule that aren't going to be exciting. And then there's ways to implement it that is going to be exciting. So I'll give you one example here. Prior authorization. If everyone goes off and kind of runs off and does their own prior authorization thing in terms of connecting to each other using FHIR APIs, what it means is we're going to have a proliferation of more payer portals. And I can tell you from talking to literally dozens of health systems, they don't want any more payer portals. They've got plenty of prior authorization payer portals, and they're not actually being used. But if we do a TEFCA-like approach at a state level, which is what the One Utah Collaborative is, that means that the actual interface on the provider side can be payer agnostic. And that means that the provider can enter it all into one user interface. And then the TEFCA-like entity in the middle, which could be an HIE or QHIN or others, can route that to the appropriate payer. And that payer can then respond back and be able to provide it. And there's less calls and faxes at the payer's office. The provider gets information back 93% of the time in real time. And the patient, most importantly, can go to their specialist and not have to wait 5 to 10 days. So that is actually the really amazing part of all of this, is what that actually looks like at scale. And that's why we're excited about the Utah Collaborative, because it's actually taking advantage of the existing data use agreements they have in place. So I'll spin through the next few of these, Marilee, and then we'll open up for questions. DQIC is Digital Quality Implementers Community. So this is related to digital quality measurement. About 3+ years ago, we said, why isn't this working? So we called our friends at NCQA and we said, tell us why it's not working. And they said, it's not working because clinical quality language, which is an HL7 open standard, isn't mature enough yet to run HEDIS measures. So we said, okay, who does that? Well, that was Bryn. So we called Bryn up. We said, Bryn, is this true? Yes, it is. We'd love your help to try to do this. We haven't got enough focus on it. So we have gathered all of the folks that have built these what they call CQL engines, and we've gathered them together in DQIC, and we said, let's fix CQL. And we've made over 200 changes to CQL through the HL7 process to standardize it to a degree that actually runs the HEDIS measures now. And now we can run at least 75% of the HEDIS measures on CQL straight digitally, all automatic, no manual intervention needed. We're going to get to 100% here in the next few months. So, and then we're saying to ourselves, man, if we can do that, then could we talk to CMS and see if CMS can just use the regulated APIs? And can we talk to JCO? And could we talk to others that are out there, Joint Commission? What are some other things that we could do to actually run this? Because remember, the two data models we have as a country right now is USCDI and the CARE IG for Blue Button. Those are the two big data models we have. So really everything that we do has got to run off those two data models if we're going to be efficient. And that's really exciting about what we've done here. That's an open community. And if you're actually building a CQL engine, we'd love to talk to you about that too. Next slide. So even if the data moves, it doesn't mean that it's of high quality. And I think this group knows that more than anything. When it's pulled out, we're like, ooh, this is bad. Oh, I don't know. I don't know if I could use this. And if we can't use it, it means that, or it's not usable, or we're trying to normalize it in different ways across the country. Then we can't run the AI models on top of it, which allows for clinical decision support at the point of care for the provider and the patient, which is really what everybody wants to do. So PICI was formed. Our friends with clinical architecture is great. And so we had an opportunity to be able to connect there with them. And now it's become an open standard, and we're going to develop a PICI, what they call a SAM model for both clinical data and for claims data. And by using that PICI framework, we're objectively scoring the data to say, actually, the data isn't really good. It's like at a 50. And the reason it's at a 50 is because of these reasons. You don't have a SNOMED code, you don't have a LOINC code, CPT code is in the wrong format, whatever the case may be, and it's not fit for purpose. And this is really, really exciting because we actually need this to make sure that the AI models are trained appropriately and that we can use the data in a meaningful way across the board. So we're super, super grateful to Charlie and his team for what they have done. They have done a service for the whole country in opening up something they were going to have proprietary and now making it a public good, which we're really grateful for. So give Charlie a hug if you see him at some point. All right. HICSA. So pharmacy, as folks know, are not in high tech, and they've been kind of on an island. But we've created this group on pharmacy. I know Sequoia's doing some work in this too, and we're working closely with them. But Kim Boyd on my team is really heavily involved in NCPDP and the other pharmacy ideas. But this is about clinical services, pharmacists delivering clinical services. And what's interesting, I didn't realize this, but there are more pharmacies in rural areas than there are primary care doctors. And so if you think about this from an access perspective, what it would be amazing if we had pharmacists delivering more clinical services so more people have access to care in their local communities, because we can do this. Now, this gets into like state laws and specifically state regulation around scope of practice. We've actually found a way around it. I shouldn't say found a way around it. We found a way through it. We don't, without changing the state regulation and keeping the scope of practices as it is, we think that we can do this in multiple different states in terms of ensuring that the pharmacists in those states actually can deliver those clinical services. So that's a really exciting project. A lot of folks that are interested in that. I think this is my last one, Marilee, and then I can open it up for questions. Is a couple more, I guess. Oral Health Interoperability Alliance. This is exciting because oral health is part of your overall health. I remember visiting a rural hospital a few years ago in South Georgia, where I live. Well, I don't live in South Georgia, I live in North Georgia, but I live in the state of Georgia. But we visited them and I said, what are your top 3 concerns? And one of the concerns that they had was oral health. They said, we have people coming in the emergency room all the time with massive oral health issues because they haven't seen a dentist or dentists are not available in their area. So how do we make oral health part of your overall health? And tons of excitement here. We've had more people come out of the woodwork about this alliance than probably any other one that we've done, because dental has always been on this kind of island, and we're trying to figure out a way to bring them in. And with the Karen IG for Blue Button, it includes oral health profiles, and so we're bringing them in naturally with some of the work we've already done, but also trying to find ways where we can be able to do that. And the fee schedule just came out this summer, or actually no, a few weeks ago, my bad, a few weeks ago, and it got finalized. And in there, it actually talks about referrals to dentists. And that was because of a lot of the Connectathon work that we did. And because we've been able to successfully do that, referrals to dentists is actually now a thing and it's required. So super good progress, fast progress that we're making there. And so if you're interested in oral health, let us know. All right. These I know are my last two. All right. How could open standards improve the healthcare experience? You're by the way, you're getting all these slides at the end. Marilee will send them to you and her team. But it's interesting that from a patient empowerment perspective, there's been so much done across administrations since the Trump administration, but certainly in the Biden administration, they continued the momentum as well. And then now in the second Trump administration, this is interesting because we have a situation where folks can select a plan, a provider, estimate their costs, check in and access their data. With the technologies we have today, we just need to scale them. And so from a technology and a policy perspective, we're there. Federal policy perspective, we just need adoption. That is actually the thing we're so focused on in 2026 is how do we get more adoption of all of these things that are already out there? And I honestly believe that in the next 3 to 5 years, you're going to see a dramatic difference in how you interact with your provider than you do today. It's going to be much easier. I don't know if it's going to be uber easy in a sense, but it's going to be much easier than it is today. And there's a lot of power in that too. So last slide, we get this question a lot. So this is why this slide is in here, is like, how does all this stuff come together? There's all these rumors is TEFCA and CMS aligned networks, are they competing against each other? Like, how do they work together? What does all this stuff mean? This is just our hypothesis and kind of what we think of what this could mean and how this potentially could look like in the future. We think that all of this makes it possible that everyone is a network now. And what I mean by that is we think everyone can be part of a network if they choose to be part of it. And so at the bottom, there's the legacy data. And that legacy data is actually going to ultimately move to these cloud-based FHIR data models. And you're going to have one with this API related information, and everyone's going to have an API endpoint, whether you've got a consumer app or a payer or a provider, whoever you are. Skilled nursing hopefully will have them as well. Others will have them. And we're going to need to know on the left-hand side that they are who they say they are. And we need to know what organization they represent. And therefore, we're going to know what data they're authorized to receive. And then on the right-hand side, Inferno and Picky are both open standards to help with the conformance and the data quality. And the top left, we think we're still going to need RLS. And TEFCA is going to provide that because if everyone pinged every endpoint in the country, that would not be a good outcome. So we need to figure out a way to know where the data is located. There's a lot of ways we could do that. We could do that with TEFCA and RLS the way that it stands today. We could do that with claims data. There's a whole bunch of ways I think we could do it. And on the upper right-hand side, we need an endpoint directory so we can find each other on the internet. So we think that this is one potential way that this could all come together. Obviously, it's probably going to come together in multiple ways, but we're kind of excited that we're going to expand the ability for individuals, organizations, entities, stakeholders to get on this network. And we think that both CMS and ONC and ASTP ONC are helping to inform that. So last slide is just my contact info. Just ping me on LinkedIn if you want to reach out. There's the QR code to our white paper if you want it. And then I'm happy to stop talking and answer questions if you've got any, Marilee.
Yes, fantastic. While people are taking a few minutes to think, I wanted to call something out on the pharmacy side. Zen was at the HLTH conference here a few weeks ago in October, and there were a number of organizations and companies that work with pharmacies, which was fun. Some pharmacy focused EMRs even to just kind of validate the fact that pharmacists play such an important role as one of the stakeholders in terms of the care team, if you will, for the patient. And I had the opportunity there to talk to an independent pharmacy, a pharmacist, not the pharmacy. Obviously, he has some independent pharmacies. We specifically, I was brought over there to talk to them about TEFCA and the opportunity. You know, pharmacists are specifically one of the named providers that can participate in TEFCA-based exchange. And we wanted to have a conversation about, well, would you even use something like that? How would you use it? Why would it be helpful? And his point is that just like you're saying, Ryan, especially in those rural areas, the independent pharmacist plays a very important role in the care of the patient. And he was even keeping that scope of practice pretty narrow. He said, we really need to see lab results for our patients on certain medications because we often are extending the care team, if you will, in a way that we need to keep an eye on how that patient is doing in terms of being on medications that can have adverse, impacts on you metabolically speaking. So it was just a great validation that to your point, Ryan, about the importance of pharmacists. And I know we're out there kind of advocating that it's a great time for pharmacies, and I think particularly independent pharmacies where you seem to have a lot of those in rural areas. And so it's great to hear that even thinking more globally. And we all know, I mean, how many of us get our immunizations at pharmacies today? I think I got all mine this year at my local CVS. So I think that's really exciting. And I think for me too, very interesting on the dental front. I've worked a lot in the federally qualified health center space. They often have under one roof, they'll have a dentist side, they'll have a mental behavioral health side, and they'll have primary care services. And knowing and understanding how important our oral health is to our overall health picture. So that's very exciting. I would love for some folks to ask questions. So I'm going to be quiet for a minute and you can just unmute yourself and start talking.
Okay, then I will.
Thank you, David.
Hey, Ryan. You and I have had a lot of conversations in the last year or so. So I'll pick one and pick it up from where it started. Using your Utah model for a state network, using the existing DUAs, that can definitely work. That can build up the state. And if we take that as a template and run it across to 50 different states, we end up with 50 independent networks. How do we get from there to national interoperability? When everybody now has tens of thousands of DUAs in place, how do we get them to say, okay, this is not what we need. We need national interoperability. We will do, and this is where you come in and say, we will do what?
So I think we need to define what we mean by national interoperability and what we need to find by DUAs and what we need to find by record location services, kind of what each of those do independently mean. So I think what I'm saying is that I don't see a pathway forward that we can start nationally with a QHIN-like model because of the DUA problem. I do see a way in which we could start at a state level, and at a state level, use the existing DUAs, but also use the QHIN-like model. Like, let me be practical, Dave. Let me give you the Utah model. The Utah model is, we got everybody, payers and providers around the table and the state, and we said, hey, we got to do this 0057 thing in the next 2 years. What do you want to do? How do you want to do this? We literally started with that. No vendors were in the room. No QHINs were in the room. We just said, what do you want to do? And they said, well, what we want a payer agnostic portal, and we want a TEFCA-like approach because we don't want to have more portals. That would be bad for us for prior auth. We need to have, and the payers are like, we need more adoption in our quote portals. And we don't even care what the interface is. We just want more adoption because we want less calls and faxes because that's too much. And the patient, of course, is like, we just want an answer, right? Like that's the issue. So So we basically said, okay, well then if we want that kind of QHIN-like model, and it also connects with obviously all the stuff that you're doing and others are doing nationally, we would say, then who do we want to choose as this kind of state's QHIN? They chose eHealth Exchange. And at the time, we actually didn't bring the HIE in. And we're like, let's see if we can just do it with them. But what we realized is that number one, HIEs provide tremendous value because they're actually accessing providers that don't get access today. Number one. Number two, they also provide value because they act as the independent broker between payers and providers to know from an attribution perspective, which as you know, isn't defined on the DaVinci APIs, if these members are actually attributed to this payer. And so we're like, oh, they just do that today already. So they could be the independent broker of this thing. That way the provider has trust that the payer's pulling information for just the patients that they, or the members that they are associated with that payer. So then we pulled the HIE in. And now we have this interesting model where it is TEFCA, but it's TEFCA in the state of Utah. And now we can be able to say, we can pull from eHealth Exchange from a QHIN perspective to pull in record location services and other data from other entities. And we can do payment and operations with the entities in that state using eHealth Exchange and the HIE there. Now to your question. The question is, how do you scale that nationally? I think the answer, I don't know the full answer to the question, David, to be honest. I don't know how that's going to work because every state has different data use requirements. That's the other issue. That's the reason, one of the reasons we had HIEs in the first place is because every state has different nuances associated with that. But if we use a TEFCA-like model in the different states, then when we do figure it out nationally, we can still on-ramp to that. The question I have still, David, is even if we were to on-ramp onto that, how do you solve the data use problem, the data use agreement problem nationally between payers and providers for payment and operations? I don't know the answer to that question. And I don't know if there is an answer other than this is kind of foreshadowing my eHealth Exchange speech in a couple of weeks. Like if you want to get really spicy, which is like, do you get rid of HIPAA? And do you say to yourself, I know that's crazy, but then you're like, maybe we need to protect the data regardless of where it sits, not necessarily protect the actual organizations, but because we now define health differently, oral health, right? SDOH, health-related social needs, you start going through the whole list. We've defined health differently now. Because of that, maybe we just need to protect the data no matter where it sits, not just say that there's actually two different regulatory constructs. Now that's a spicy answer. That's probably not going to happen in our lifetime. But I guess my point is like, how do we figure out a way to think about this problem differently so that we can be able to scale it nationally? Because you're right, we need to scale it nationally. We're not interested in doing 50 states. We tried that with HIEs, it didn't work. But we have it differently now because we can implement a model at a state level that could be replicated nationally. We're certainly not doing anything in Utah that's different than what you're doing nationally. We're just operationalizing it faster because of the fact we can take advantage of the current data use agreements. I don't know if that answered your question, but.
Yeah, nope, that's great. Thanks.
Okay.
I'm curious, Ryan. I know Utah is a little bit unusual because not only do they have the HIE supporting clinical data exchange, but they also have the state runs their own EDI clearinghouse, which tells me the state probably already had really good relationships with those payers because of that clearinghouse model. Do you feel that played a role in how quickly they could kind of get to success and collaboration?
I think when the governor calls you and said you want to do something that's a priority for you, that helps, right? Like I'll just be honest, Marilee, like
Yeah,
that's
sure.
super helpful. That's why we're having conversations in a dozen other states, and we're trying to also get governors in those states, Democrat or Republican. At this point, we don't care. Like this is a good idea. And we're actually focusing, Marilee, more on states where all the providers are connected to like an HIE, like a Connecticut, like a Michigan, like a New Jersey. Like this is actually pretty exciting because then I'm like, oh, we don't have to like call every single provider. We could just set up a QHIN-like entity here and use the HIE as that QHIN-like entity. They have eHealth Exchange as an on-ramp already because nearly all the HIEs are connected to eHealth Exchange already. And like, hey, there's your on-ramp, right? That's a great on-ramp. We're good to go. We've got the national connection. We've got the local connection. And the combination of those two things is really, really valuable. So that certainly helps. I will tell you, Marilee, this is of no surprise to anybody on this call. the hardest part about this entire process was actually getting them in a room together to talk about something other than contracting and fees, because they don't hang out at the local coffee shop together, right? Payers and providers, I'm talking about. Like, that's not a thing. Usually when they hang out, they're arguing about contracting and fees and rates and all that stuff.
Yeah.
And so the tenuousness on that relationship is so strong right now. And I would call that a net zero sum game. And what's interesting is because everyone is hurting right now, whether it's patients, payers, providers, government, like everyone is hurting. So now they're like, maybe we're playing the wrong game. Maybe we need to play like a non-net zero sum game and try to find ways where we can all win. Like, can we all win? And the cool thing is these rules that have come out, like prior authorization, others, this is an everyone can win scenario. Patients get more timely, 93% of the time. Early adopters are telling us 93% of the time they get an answer back in real time. That's insane, right? Most of us are waiting 5 to 7 days for a response. That's number one. Number two, the physician gets an answer back. In fact, 85% of the time, the answer that's back is no prior auths required. That's great. Go on, go to the specialist. You're good, right? And then the calls and faxes decrease at the payer, so they can hopefully reduce premiums. So like, it's like, all right, let's do this. Like, this is an exciting way to go. And I think that we're trying to get them together for reasons other than contracting, and that has been very hard. But you can imagine one other thing real quick. We're so excited about the Utah stuff. Public health is at the table too. And our public health friends are like, we can't get access to the data because the payers won't send it, the EHRs won't send it, all this stuff. I'm like, have you just asked for the USCDI API? It's in production. Just ask for it. Like, they're not going to do anything different. They're just going to redirect the API to you. And you can do case reporting and syndromic surveillance and everything you need to do. Just redirect it to you. And they're like, wow, that's right. I never thought of that. So now guess what they're doing? Just send us the USCDI API, and whatever it is, the 14 public health authorities in Utah are now getting this information that they've never had before. And now they're getting more data than they've ever had previously. So this is the benefit of reusing the APIs over and over and over again for multiple use cases that everyone's authorized to receive, minimum necessary, all that other fun stuff, but that they can now get access to the stuff that they need so that we can stop spending money on stuff that's stupid, like the dumb stuff. I don't want to pay money on just getting the data from point A to point B. I want to spend money on actually getting people healthier, better, well, all the other things that we want to do. And the fun stuff that Gene and everybody else is like working on. This kind of fun stuff is kind of the idea. Anyway, you get me started now, Marilee. Get me excited about this stuff.
Well, it's fun to actually be able to talk about something that has the word payer in it. That's really that's really happening. So I want to open it up to others. So first of all, I saw Lisa just put a comment in, but does anyone else want to just jump in? Jean, I was looking for your face. I figured you might have your hand up. Go for it.
No, well, and then Ryan called me out, so I really appreciate that. So Ryan, so I just did a deep dive because I'm very, I do nothing in interoperability. I'm just the receiving of it, right? So continually looking for great data partners and whatnot. And from the viewpoint of a family or a patient trying to collect this information to interface in different ways and do some of the care coordination. So I'm definitely outside the EHR solution. So I was very interested in how all the payers were approaching the CMS thing in January. And it has been hugely disappointing going website to website and seeing I get it. They had to meet certain things. They had to educate the consumer on privacy and consumer apps. But it is not easy to understand as a patient how to access that API. There's links to random websites that are broken that don't show me consumer apps. I was really proud to see Karen Alliance was often referenced, like you can see that they didn't get good guidance on, hey, we just did this checkbox thing for CMS, but we really don't know what else to do to direct patients to really empower them to that next phase. I was going to start personally reaching out to people and educate because, that's my style. I'm all about collaboration. Any tips on things I can say? Like, it feels like they just did this checkbox, did a ton of investment on it, and then don't think about the ROI of this, right? So I don't know. Any thoughts there because I don't want to... I like your use of spicy. I don't want to be spicy to people because I'm a nurse. I just want to help people. But what can we do
Well,
to get payers interfacing with patient access?
we need more spiciness, Gene, and you're very spicy. Spicy is a good thing. It's good to be
It is, yeah,
spicy.
right.
I would say that remember, patient access was the first time that we implemented FHIR anywhere. When patient access first started, just so you know, it started mainly on the physician side. EHRs actually supported with the Argonaut project and MIPS program, et cetera. And it was somewhat of a check the box type initiative. Like they were kind of going through it, not many people, it wasn't a big demand. But then the payers showed up because of the CMS rule in 2020, right? They started like showing up. And when they showed up, I'm not kidding you, major payers were like, how do you spell FHIR? Like, what is FHIR? Remember, because they were all in X12. So in the last 5 years, we have taken it from how do you spell FHIR to the payers actually supporting this really well. Like they have developer portals. You can go like developers.humana.com or
I've got them all
developers.aetna.com.
linked. If anybody wants
Like,
that list, I have it.
It is awesome. FlexPA has an open directory too. FlexPA's got a whole payer directory that's all open source, which is great. CMS is building one. It's awesome. But payer providers now have to go back and figure out what are they going to do. And many of the providers have delegated this to their EHRs, which is understandable. But what the providers are realizing is because they can use the APIs for things other than just the treatment stuff and the EHR related use cases, they need this data for a whole bunch of other reasons. So a lot of them are saying, we want our EHR for sure, but we also want this data in a cloud-based data store that we can be able to manipulate and send and do all this other things, quality data reporting and all the other stuff that we've got to do to CMS. Remember, bulk FHIR doesn't really work really well with the EHR. So like, how do we actually send bulk FHIR data from our cloud-based data store to our payers so that it becomes easier to do that? And digital quality measurement, like all that stuff, that is going to happen. So to answer your question, a long-winded way of saying, Gene, we're still in the early innings, and we've developed in Karen, it's on our website. We can send it offline, but there's a whole set of like best practices around how to set up a FHIR gateway and how to be able to connect to these endpoints. And that was my point earlier about we wanted to send out best practices for how to do this, because now for the 0057 rule, everyone's going to have to connect with everybody, right? Payer to payer, payer to provider, to patient, all of that stuff. And that you want to see craziness. We have basically told anybody that'll listen, payers and providers, if your API strategy is not core to your business strategy, you're behind. You're behind. You're way behind. And because that is going to enable everything else in your business to work and operate at scale, because you're now going to have structured data elements coming through a modern technology stack, which you can start to hopefully be able to sunset some of that older technology like X12, if we can get CMS to cooperate on, not having these X12 transactions and have prior auth more be FHIR based. If we can do that, like then this stuff starts to scale, and it scales in a way that's better than we have today. So I know you kudos to all of you patient apps that are out there, because and you should give a hug to all of your patient app friends, because they literally have gone through, and they complain to me all the time, which I'm super grateful for, but they're literally cutting a machete line in the jungle of data exchange and interoperability of stuff that's never happened before. And because of them, this is going to be easier for everybody else. And that's really, really beneficial. And kudos to you, Gene, and everybody else, the BeWells and Citizens and FlexPAs and everybody else in the world, because it's really powerful.
No, and I'm excited. I'll be at the American Medical Informatics Association, one of the 9 apps showing off FHIR. So I'll be talking about it.
Awesome.
That's wonderful. Lisa, you have a question that you posted in the chat. Would you mind unmiking and throw it out there for Ryan?
Sure. I was surprised, Ryan, to hear you say, hey, let's get rid of HIPAA, because man, oh man, HIPAA was not designed for this, right? And it creates a lot of problems. And on, the upside, it does protect the data. On the downside, it also doesn't kind of articulate this new environment with API vendors. And there's been a lot of learning in systems and in communities about the incredible data cell. So we talk all the time about moving this data for the treatment and care coordination aspect of this, which patients for sure are all in for when they turn around and go, well, what are they doing with my data at the payer level? And they find out that it, or they recognize that it's been sold 25 times thereafter. It's a bit of a problem. So the trust in the system is fully broken. How do we respond when people come to us with those concerns? How do we say what happens with the data? It's not articulated in HIPAA about these API vendors. Let's just deal with them.
Yeah. Well, I want you to think about this. Everybody's got a lot of experience here. Does HIPAA really protect the data? Let's think about this for a second. Sure, there's high trust. There's data use agreements, there's contracts, there's fees, we know the whole game. We got it. We've all been doing this for a long time. But think about this for a second, to your point about reselling. We don't know where the data's going. We don't know who has it. We don't know who's got the information last. We don't have audit trails. Let me give you the flip side with what we're doing in the Care Alliance, what we've done with our partners like Gene and Apple Health and everybody else. Well, number one, we are requiring that everyone gets identity proof, the patient themselves, which is a higher bar for the patient, which means, and the flip side of that is because it's a higher bar for the patient, it means it should be easier to get access to the data because we have better identity protections than anywhere in HIPAA. That's number one. Okay, so it should be easier for the patient to get access to their data than anybody else. That's not the case today, as Gene knows, but that's number one. Number two, we're using modern technologies. We got these flat file CDA things that just, it's totally insecure. X12, it's just not right at all. Data breaches. Third thing is, guess what Apple Health does with your information? It takes the information, never touches their cloud store, goes directly to the hardware of your phone and never leaves the hardware of your phone, doesn't touch the internet at all, never leaves the hardware of your phone unless you physically consent, not a legalese document. It says, do you want your data to be sent to Gene's app? Yes or no? Yes, I do. And then it gets sent over and I'm making the decision for myself. And then we have the Care and Code of Conduct that uses HIPAA and GDPR and CCPA and all the best ideas from around the country that then binds the folks that Gene works with in the FTC environment to the same standards that Gene has to sign for the Care and Code of Conduct. I would much rather have my data work that way than I would inside of HIPAA. So we have taken HIPAA as a floor, not a ceiling, and said, holy cow, folks, we've learned a lot in whatever it is, 30 years. We need to figure out a way now to put that everywhere. And to Marilee's point earlier about FQHCs, we can't make all these FQHCs and these, housing service providers go get high trust certified for $100,000. They don't have $100,000. That's insane. Now, do we still need to protect the data? Of course, we need to protect the data. And of course, we need to make it consent-based. But we can do that for a heck of a lot less than $100,000 to do that. Like, that's just insane. So I guess my point is HIPAA's likely never going to go in my lifetime, right? But my point in all this is to say, I think we have actually convinced ourselves that data inside of HIPAA is more protected than data outside of HIPAA. I don't believe that that is correct any longer. Now, are there nefarious apps inside the FTC environment? 100%. You've seen all these fines with these different organizations, women's health, women's fertility type, yeah, not good, bad. But that's why we have created this voluntary protected framework with the Care and Code of Conduct inside the FTC environment that is a higher standard. It takes all the best of HIPAA, it takes all the best of the FTC breach notification rule, and that stuff is in there so it protects the data better than it does today. So I think that's my biggest point. And I don't know if that answered your question, but like, to me, I feel like we need to use HIPAA as the floor, not the ceiling. I think that's my big point here.
I totally agree. I guess I'm still confused as to how do I respond? Like with the app providers specifically, when you're bringing them in and you've got this limited understanding, I honestly don't know the answer when somebody says to me, how do apps have to behave and what happens to the data that goes towards these apps and through these apps?
you should look at the Karen Code of Conduct, and you should look at myhealthapplication.com about the apps that have signed the Karen Code. Not all of the consumer-facing apps have signed the Karen Code, and not all of them are listed on My Health Application. And I would be cautious about those. We know who they are, and we know what they're doing, and they're not doing things that are consistent with the code. And we're not really a vetting organization per se. Direct Trust is actually doing a whole certification program for it, but we have like a light vetting process. But I'm like, dude, you're downstream, you're selling this stuff without even telling the consumer. Like, that's a hard no. Like, that's a totally hard no. You're not going to do it. Now, there's some that have, stage 4 colon cancer, and they're like, I'll put my data on Facebook or anywhere else so I can get a treatment for that. That's their choice, but they're going to make that choice themselves. We're not going to make it for them. And so anyway, I would say there are a lot of really good HIPAA lawyers out there, and there are a lot of actually really bad ones, unfortunately. And some of the bad ones are giving us advice like data can never leave. And if you're a consumer facing app, you've got to sign a business associate agreement. Like, they don't understand what this is about and why these apps are actually very trustworthy. So we're happy to take that offline and talk to you more about it. But it is it's something that's really important for folks to understand that again, we have always in the Karen Alliance viewed HIPAA as the floor, not the ceiling.
And I also think that TEFCA is doing the same thing. If you look at for those of you who are familiar with the individual access services SOPs published there on the Sequoia Project's website under the TEFCA area, I mean, it's a very detailed requirement around the notifications, the privacy notifications that those app builders have to build into their applications. It's very prescriptive. So it's certainly not going to solve every problem, but it is, to your point, Ryan, it's raising that bar significantly. And it's another way of knowing when those apps are knocking on your door, if they're coming in through TEFCA, there are very high bar requirements. And I can tell you as a gateway to TEFCA, working with Commonwealth as a service adopter, there's a lot of barriers for our customers to get certified and get past that review, both the Zen's review and then another layer of review there at Commonwealth, and then the final layer of review when they get submitted to TEFCA to go into the directory. I know we are bumping up against time. We only have a few minutes left. I just really want to thank everyone for attending. If you have any final questions, please throw them in the chat, and we can either Ryan or myself can get back with you. Afterwards, we will be sending the Ryan slide deck out after the call, and then we also eventually this call makes its way to our YouTube channel for Marilee's Office Hours. So we do have access to the content. It takes a little while to get over there, but it will get over there. One final, just a news note for those of you who are participating in Carry Quality. Carry Quality is in the middle of publishing some guidance for the delegation of authority business processes, which most of you who are participating know that's a fairly new process, just started in May. There's been a lot of confusion and it's been a little difficult to navigate. And the community came together and encouraged us to do better in terms of communication. And that is actually, we're in draft mode right now. There will be some written guidance coming out of the Carry Quality team. We're very excited about that. It's going to make everyone's life easier. And with that, I will wrap things up. I hope to see many of you in Nashville next week. Ryan, I'm sure I'll see you there. Yes, looking forward to, and David, I know you're there, and hopefully others, to 3 fun days at Nashville. If you're not at all 3, we'll catch you at 1. Zen will be there for all 3 for sure. So thank you, everyone. Really appreciate everyone's attendance. Ryan, thank you so much. This was fantastic. See everyone soon.
Thanks, everybody. Take care.
Bye.
Thanks, all.